Hello, everyone, and welcome to the American Society of Regional Anesthesia and Pain podcast, ASRA Wrap. I'm your host, Raj Gupta, coming to you from Nashville, Tennessee, and I have such a great show for you today, and you're going to love the people I have on to talk to you about private practice anesthesia and some of the lessons learned from private practice anesthesia that's applicable to all of us doing regional anesthesia, acute pain, chronic pain, and just managing our anesthesia practices out there. So I will get to my guest in just a second, but I do want to share a couple of special important things with you. So first off is announcement about the ASRA Spring Meeting. This is coming up very, very soon, April 20th through the 22nd. And it is going to be in Hollywood, Florida. Now, Hollywood, Florida is right between Fort Lauderdale Airport and Miami International Airport. So two great airports that you can fly into, very close to that location, right on the beach. It's a wonderful place for you to come if you want to come and relax and enjoy the conference, or also bring your family. There's a lot of wonderful things for your family to do as well. And it's going to be a phenomenal meeting. Dr. Haskins has put together an amazing program with new faculty, a lot of specialty topics, unique topics, and I think it's going to be really, really great. The other thing is this is the 100-year anniversary of the original founding of the American Society of Regional Anesthesia and Pain Medicine, way back by Gaston Labat in 1923. And there are going to be some special events, special speakers, special things to commemorate that history of the organization and of the specialty. So this is going to be a really important meeting to be a part of and join. And then, of course, just to get together with colleagues that are all sharing the same passion that you are. A couple of things I do want to mention. There are some specialty workshops that you've never seen at the ASRA Spring Meeting, particularly one on fluoroscopic guided epidural placement and neuraxial procedures. This is a limited access workshop. We've never had it at the Spring Meeting, so I encourage you to go to the website, register for the meeting, and sign up for the workshop before all the slots are filled up. And I think they will be all completely full very soon. So very, very important to go do that. Now, as always, ASRA has a bunch of events coming up, so I encourage you to go to their website, asra.com, and look at the events calendar. There's webinars, there's online sessions, there's in-person workshops, all kinds of stuff happening throughout the year. It's not just these two meetings that we do twice a year. It's year-round. There's content that's delivered from all kinds of experts from around the world, so I encourage you to go check that out. Now, I do want to talk about our topic today, and this is focused around the private practice special interest group. Now, if you don't know, the American Society of Regional Anesthesia and Pain Medicine has a variety of special interest groups that focus on specific topics within our specialty. And the private practice one is one of our newer ones that's been around for a few years now, but has gained tremendous following and enthusiasm early on. I think that you will find a lot of content coming out of this group, and one of the things is our session today. So let me take this off the screen and bring our guests back on. Hang on one second. And let's get everybody back on. And we got one other guest, Dr. Norenberg. She's got a little bit of technical issues, and there she is. All right, perfect. Got everybody on. Hey, everybody. Thanks for joining me.
Hey, Raj. Thanks for having us.
All right, so I'm going to do intros, and these people are so good that the intros are going to take a minute. So just bear with me here while I read off some of this amazing stuff these people do. So first, I got Jenny Norenberg. She's a board-certified anesthesiologist, completed fellowship in regional anesthesia and perioperative pain management at Washington University in St. Louis. She's completed residency at the University of California, Davis. She is a partner physician with the Southern California Permanente Medical Group and works for the San Diego region. Her interests include working to develop perioperative pain protocols for several types of surgical applications, developing tools to educate both patients and physicians of resources for multimodal and regional anesthesia, and recently taken on the role of enhanced recovery after surgery anesthesia lead for Kaiser San Diego. I didn't know that, Jenny. Good job. As well as the California Society of Anesthesia Wellness Task Force Chair. Just booming. Jenny, it's great to see you. It's been a while. We haven't had a
I
chance to talk in a
know.
long time. It's really great to have you on here.
I'm super glad to be here. I can't wait to have this whole discussion.
Yes. Okay. Second, Gary Schwartz is the Director of Acute Pain Management at Maimonides Medical Center in Brooklyn. He is a board certified in both pain management and anesthesiology. Dr. Schwartz completed his interventional pain fellowship at Mount Sinai School of Medicine and finished his anesthesia residency before that at St. Vincent's Hospital in Maimonides Medical Center. He received his MD from State University of New York Upstate College of Medicine and graduated magna cum laude from Union College in Schenectady, New York. Dr. Schwartz focuses on back pain, neck pain, spinal cord stimulation, nerve pain, joint pain, failed back surgery syndrome. And at Maimonides Medical Center, Dr. Schwartz focuses on assisting hospitalized patients with post-op pain. He also educates anesthesia residents, med students, serving as the committee member for the Azra Pain Medicine and the American Society of Anesthesiologists. And Gary, I pulled off all of those pronunciations without messing up one. I even got Schenectady right.
Schenectady and Maimonides in one paragraph is quite impressive. We could end the podcast now. This is just that.
I know.
We're not going to
That's
stop
the
that.
first time I did that right. So
I'm
great to see you, Gary. So
Thanks
glad
for
to have you
having me.
here. All right, next up, Melody Herman. Melody is the Director of Regional Anesthesia at Carolinas Medical Center. She's completed her residency at St. Luke's Roosevelt Hospital and Regional Anesthesia and Acute Pain Fellowship at Massachusetts General Hospital. Most notably, she's began creating short regional videos called the Nerve Block TikToks in 2020, a good pandemic activity to do, and has actually grown quite popular because of that, and they're really creative. Dr. Herman is an associate faculty for the Azra Pain Medicine Society and has served as a newsletter liaison for the Private Practice Special Interest Group and now serves as ultrasound representative for the European Society of Regional Anesthesia International Committee. Melody, it's great to have you.
Thank you for inviting me. So happy to be here.
I feel like we're appropriate. We have you in the vertical format. That's on the video
Oh,
here.
yeah.
So.
As everybody knows, and I'm TikTok.
Yeah, you're TikTok formatted. We need to just keep you that way because that's your frame.
This is my home.
All right, next up we have Dr. Jerry Jones. He is the Azra Pain Medicine Private Practice Special Interest Group CME liaison. He's a board certified anesthesiologist and has assisted in the implementation of numerous acute pain services across the country, served as the division chief of regional anesthesia and acute pain medicine, as well as the acute pain service director at the Elvis Presley Memorial Trauma Center in Memphis, Tennessee, and then with Regional One Health, also in Memphis. He's recently returned to private practice with East Memphis Anesthesia Services and is now an adjunct assistant professor at UTHSC. And Dr. Jones continues to speak across the country on new innovations in regional anesthesia and acute pain medicine. Jerry, how are you? Great to have you here.
Glad to have you. I guess we're probably the closest, aren't you? Are we?
Yeah, just Nashville, Tennessee. Yeah, just a short. Although the Carolinas are pretty close. I'm kind of right between you and Melody. So
yeah, maybe so.
Well, I am just so lucky to have you guys on here because all of you guys are friends. I've known you guys for a long time now, and it's just such a pleasure to have you on. But I do want to talk about something other than how much fun we have together. I want to talk about Private Practice Special Interest Group and what you guys are doing in the field. We have several topics that you guys brought up and then a couple of questions that came up in the Twitter feed. So we'll kind of build off of that. Gary, I'm going to start with you. One of the topics that I think jumps out always when we talk about private practice for some reason, more than in acute medicine, is about billing. And I don't want to go into a long diatribe about billing because that's hours and hours worth of conversation. But I think my question is what can all practices learn from some of the strategies that are developed and sort of tuned in private practice? And whether you're the person doing the coding, what should everybody know about billing?
That's a great question. Number one, I think Azra has a lot of great resources. They have the Coder Rep, which gives at least the work RVUs and the CMS to Medicare reimbursement for the current year on the Azra website. They have the recent coding updates as of January 26th, just Azra.com. that's available to all the members. So it's important for the codes and the bills that every private practitioner has to obviously know, because that's how we pay the bills, but also for the academic physicians, our residents in training, and our fellows. And we should understand how our coders work, what the RVU, the relative value unit is, and how we get paid, because it helps us better understand what we do. And we should get paid for the work that we do to care for our patients. So it's important to understand what you're billing. Like, what is the value of, let's say, a tap block with ultrasound guidance versus nothing, versus a general anesthetic? For our chronic pain practitioners, what's the value of a spinal cord stimulator trial versus like an epidural, let's say, versus an office visit? When you eventually, at some point, whether you're private practice, academic, national group, you're going to have to renegotiate a contract or potentially change jobs, and you want to know your worth. So I think that's why it's very important. As an aside, also, ASRA recently last year, with the leadership of David Provenzano and the executive director, Angie Stengel, got a seat at the American Medical Association House of Delegates, so they could play an active role in creating CPT codes and becoming more active in the billing and reimbursement for our members, whether it's acute, chronic, or transitional pain.
Yeah, that's a really important point. And I want to emphasize the American Medical Association. So this isn't the ASA that we're being part of, because we're already part of the American Society of Anesthesiology. This is actually getting a seat at the table at the American Medical Association, which speaks right to Congress about how Medicare, CMS, Medicaid, all of those pay out for the work that we do. And now we have a voice at that table. Gary's helped participate in that in the past as well, to kind of see how how all of this gets cooked behind the scenes. And we want to make sure that our advocacy is in there as well. So if any of you guys who are in the audience are interested in this topic, make sure to reach out through the society and say, hey, this is something that's being missed, and we need work on this area, because that's how advocacy goes up the chain and starts making changes. Otherwise, we're kind of at the whim of other people.
And please,
Jenny?
join, if you're not a member of the AMA, just start to step over you on that one, Raj, because to keep our house seat for ASRA, we have to have a certain percentage of members who are AMA members, and potentially get more seats in the future. So if you're interested and passionate about the specialty of regional anesthesia and chronic pain, it's worthwhile to fight on Congress to make sure we get paid for what we do.
And there are opportunities for people to get involved in that and actually be either a delegate or a sort of a learner delegate. So we have backup systems to kind of build people up over time. So even if you don't know much but are interested, we have a process to kind of shepherd you through and teach you a lot of this material so that you can be very vocal on it and learn it yourself. Jenny, you work in a very different environment in private practice. Kaiser's a big organization. How much do you guys have to think about billing in that environment, and what do you think people should know, even if they're working big private practice groups?
Well, that's actually a really funny question, Raj, because that has been an ongoing saga with Kaiser. So for a really long time, Kaiser has been self-insured. Sort of lesser known fact about Kaiser's actually three different entities. We have the Kaiser Health Plan, we have the Kaiser Foundation Hospital, which hires all of our nurses and runs all of our buildings, and it's basically, if anybody knows the University of California program, the UC Regents, is a similar idea to what KFH or the Kaiser Foundation Hospital is. And then finally, we have our physician groups. So those are divided. We have Southern California, Northern California, the Pacific Northwest, so Northwest Oregon and Northwest Washington. And then we also have groups in Colorado, in Georgia, and then also in the DC area. So each one of those are a different separate physician group, which is like, a lot of the private practice groups around the country, like Somnia, for example. And we all choose to exclusively contract with the other. So in the past, the Kaiser Health Plan has been able to basically self-fund all of our patients. And it's only been in the recent past, maybe in the last 5 to 10 years, that the way that our healthcare has been going, we've been accepting more Medicare and in California, Medicaid patients And it has become, especially during the pandemic, increasingly important for us to actually do proper practices to submit our documentation for billing. So that has been a really interesting process coming from private practice prior to joining Kaiser, and advising my colleagues in terms of doing documentation. And so that's been a great help from all of my colleagues at ASRA, that we have a receptacle of documentation for block notes, for pre-ops, for PACU follow-up, acute pain, all of that, where we've been able to have a little bit more standardization so that we can ensure that when our billing department ends up submitting to Medicare, we actually have a somewhat chance of getting reimbursement from Medicare. Now, it's still very, very, very much a work in progress. And we've had definitely years of being in the red, partially because we don't bill very well. But I'm sincerely hopeful that we continue to build that knowledge base. And I encourage any of the folks that I work with, especially those that have a keen interest in regional and acute pain, to join up with ASRA, because those resources are invaluable to be able to advise and educate the department for somebody who, in the past, they've been like, oh, those doctors just aren't very good at documentation. We don't have to worry about billing. We're fine. Mm-hmm. So billing across the board is super, super important. And very complicated. So Fury is helpful
to
too.
All of us.
It does. It really does.
It applies to all of us, because even in academics, if you're not generating income, they're going to basically make you stop doing clinically what you're intending to do. And we've been working for years to build that repository of startup documents, basically within the society, that you can kind of go into and say, I'm starting from a blank page. Where do I even start to make sure that I'm not missing big chunks of stuff? And then obviously there's opportunities to customize or make it locally unique, but at least you've got a starting point that captures most of the key components. So huge resource that you guys in the special interest group have put together over the years, and I think that's really, really important. Jerry, I want to get to you about actually, sorry, I'm going to go to Melody first, and then I'm going to go to Jerry. So, Melody, one of the things I wanted to ask about is, the differences with how we approach regional anesthesia, both from a clinical perspective and a financial perspective, as we keep pushing this stuff out to ambulatory. There's a lot of movement for total joints to go out to ambulatory, but there's more stuff moving, and regional anesthesia, better pain management is a real key component of that. How have you guys worked on your shift of cases and volume to ambulatory, and what does that do in private practice?
Sure. So my private practice experience is a little bit different. So we are modeled as a private practice, but I work in a level 1 trauma facility. It's the county hospital, basically. And we're kind of merging into this like hybrid academic private practice arrangement where we're staffed as private practice. So you'll be covering up to 4 rooms. We don't have residents. We only have, we have CRNAs, but we do have medical student rotators. So what I've seen on my end with the shift of, less acute going out to more ambulatory centers is just higher acuity where we're working, which, regional has made all the difference from that. I had a patient, gosh, it was like a couple weeks ago, that had an EF of 5% for a pinky amputation. And this is a hospital, 3-4 years ago, we did no blocks, and now we do about 300 a month. So I would say, as far as regional anesthesia and the change of higher acuity going to, the level 1, and, I don't really see an ASA 2 that much. I think that, showing our worth and showing our value, the value of our service, and making the anesthesia, safer for the patient. The hospital is saving money by decreased length of stay. The opioid needs of our patient are reduced. They're meeting milestones to discharge sooner. We definitely see that firsthand every single day.
Yeah, and that's a good point that a lot of people don't talk about. We spend so much time talking about how do we get these cases to ambulatory. We forget what's left at the center. The inpatient side are getting sicker and sicker and sicker. And so the complexity of taking care of those patients is a new problem to solve in this equation. Jerry, I was going to come to you with a similar question. You've worked in both sides. You've worked in big hospital centers. You worked in ambulatory centers. You work in a big orthopedic place now that does a lot of ambulatory surgery. Talk to me about that process of how do you make that work? If somebody's trying to do more cases out in ambulatory, particularly total joints, which is the hot topic, what do they need to be thinking about? How do they make that effective? And we did, if you want to piggyback it, I'm going to extend this to the other people too, is one of the questions that came on Twitter was, how do you make something like peripheral nerve catheters work in a private practice setting with less resources, less trainees around than an academic place would have?
Gosh, yeah, that's
too many questions, but
yeah, that's, and I'll just say something about the last part first.
Yeah.
That's part of one of my real interests in regional anesthesia and doing things with the private practice SIG is, in general, the default is, well, I can do a single shot block, all those catheters, that's too much trouble and too much waste. And I don't know. Well, it's not true. It's just not understanding how you make all of that stuff work. But I'll just table that for a moment. I think that's important because I really think we do more for patients when we can extend the analgesia longer and other things like that. And we did that in the trauma center with all kinds of crazy things. And I see opportunities to do it in our outpatient surgery. We do like 150 outpatient total joints a month. And not everybody would say need a catheter, but there are certain people that would particularly benefit. And because of that, you might be able to slide even more patients out to your surgery center. But going back to how do you make this giant system work where you can take these sicker and sicker patients and bring them to the ASC and reliably get them home? Well, number one, you got to be good at regional. That's a huge thing for making things reliable and predictable. It happens all the time. That we can get people out quickly. Nobody's nauseated. Nobody takes opioids. Everybody goes home and does fine. But the biggest thing to really make this work in an outpatient surgery center is preparation. Like, you've got to have a good pre-anesthesia assessment process. Honestly, you have to have reliable providers. If you're going to go, okay, whoever that you go to for your cardiologist, sure, I'll take their note. But just asking someone in the community, hey, can you see this patient, or send me your last office note, finding people that might help to make that, because then you want people looking into all these details, but you want people who know what they're talking about, or more importantly, they know what you're talking about. So really, a lot of it is the prep work up front, so that it's a disaster to walk in and at 7 o'clock in the morning and realize, actually, I had somebody today. I had somebody today that reviewing their things yesterday. Guy doesn't take so good care of his health and this and that. His potassium, they finally sent us the potassium level, less than 24 hours from surgery. It was 5.8. I'm sure it's hemolyzed, but you can't do that to me. So we had to roll and jump. So he was a first case start. So luckily, just having a good system in place, we were able to find a place where we can get him in. Couldn't do like an ISTAT in a surgery center. So we were able to put him in a place where we could check that again and make sure it's fine. And instead of making him in the first case, we put him at the last case today. So we still got the case done. So it's a lot of preparation, I think, that goes into making sicker and sicker patients work in an outpatient surgery center.
Jenny, you want to piggyback on that? I know you've got a presentation coming up at the spring meeting about this. Talk to me a little bit about this big push for ambulatory total joints.
Yeah, no, thanks. And I love what Jerry was talking about, because unfortunately the epic battle continues with trying to find the ultimate way to extend somebody's analgesia and be able to manage the communication and the administrative aspect of perioperative pain, and that I think will continue to evolve. But sorry, the lights just turned off in the office. And I think one of the most important things that we've noticed is the cooperation, and Kaiser has done an incredible job coordinating, all of the various services that are required for total joints. So we have a very robust home health program that sends physical therapists and nursing care out to the patients for the first couple of days after surgery to ensure that they are safe at home and that they are participating and not having early signs of complications. They also get a home evaluation prior to qualifying basically for an outpatient surgery. And so I think patient selection, as Jerry was talking about, and planning for that is just incredibly paramount, and having all of the various services on board to be able to support sicker and sicker patients that are going to go home. And, when we started at Kaiser in 2016, we were so incredibly careful about patient selection. They couldn't be over a certain ASA. They couldn't be over a certain BMI. They couldn't be a diabetic. They could barely have any heart disease. It was just like the healthiest of the healthiest. Now we have patients rolling in with an EF of, 10%. I don't know if that's bad, but anyway, I might be exaggerating a little bit, but regardless, so these patients that roll in, you're like, yeah, we're going to send you home. It's going to be fine. And for the most part, it is. And we've been tracking all of the data for that, and making sure that we're continuing to have positive outcomes. But the main reason for that is really the communication and cooperation of all of the various services and the planning. I honestly would say probably 90+% of our total hips and total knees go home the same day. Our total shoulders, I would say, probably is at least 65%. And I don't know why we're not higher than that with the total shoulders, but they are receiving single shot blocks. Cause I have continued the uphill climb of convincing somebody that a catheter is a good idea, and it's not hard to manage, but, we'll see if that ever changes. But I think that that's important to know that, again, having all of these colleagues around, discussing various pathways and protocols to say, I really want to figure out how to do this. What do you do? And who did you get as your advocate for getting this initiative pushed forward? And having those resources around the country and these different types of practices has been incredibly vital and important to making various evolutions of our clinical pathways. And so, I can't speak highly enough of just the cooperation that we have, and that I hope that we all get to continue, because we're not done yet. We're at 90+%, but what are we going to do for that last 10%? Do we have to send them over to Melody's and Jerry's centers where we have to, get creative, or are there ways that we can continue to optimize them preoperatively, or put in a catheter? I don't know. So all those kinds of things to see if we can continue to improve. So I think Gary's got a piggyback over there.
I think one piggyback, I know Raj and I have spoke about this before, and I know you're hitting 90%, which is great, but in the private practice, let's say private ASC, not a hospital system, to maybe increase revenue, you can't have 100% success rate. If you just say, I'm going to have ASA ones, BMI less than 30, you're going to leave a lot of total outpatient hips, knees, and shoulders on the table. That we're not pushing the edge is not the right word, but I think we could expand this to a lot more patients as we've increased our regional techniques, whether single shot and or catheters. Mm-hmm. But there has to be some people that are borderline that you try to get ambulatory, because you're leaving too many patients on the table, whether you own an ASC or just work there as a private practice anesthesiologist, that we have to consider for the future. Also, some insurances are not going to be paying for the healthy hip, healthy shoulder, healthy knee to pay the extra fee for an HOPD inside a hospital. So we have to be cognizant of that for the future as well.
Right. So obviously to be successful, you do want to take the healthier versions of those and get your system down to where you have a little bit of room for error. Because I the same thing that you guys have done. earlier on, our standards of these are the only people that can come, and it gets wider. Now we'll do people the BMI 50, maybe. We have to look at them, but I mean, I'm saying, but that's what you start simple and really work on your system. There's a variety of ways to do it, and this is actually one of the things that I think can be one of the huge values of this SIG and the people that are interested in this. It's amazing to go out into all kinds of different communities and everybody to hear someone's figured out a solution for something that you never could. Someone else figured out a solution for that. Or if we can kind of pool these ideas together, because again, what is a rising tide raises all ships, or however you say that. If we can figure out how to do that better and better and better, I mean, that's really how we're going to show what our subspecialty can do. We're not just say, isn't it neat? We did some academic thing, or we lowered something. Make it work. Make it work to where this can work in private practice, and it'll take off. I mean, and again, I appreciate the comment about the uphill battle about catheters. It's not hard. It's just a system. You have to have a system. Convincing people of that is beating your head against a wall, though.
Yeah, it's change is hard. And one thing I would comment about total joints in outpatient settings is I realized in the conversations that I've seen when people talk about it or publish on it and stuff like that, we're not all talking about the same thing when we say outpatient surgery center. So there's outpatient surgery center attached to the hospital by a hallway. There's outpatient surgery center that's across the parking lot, but in the same building. And I mean, and then there's the outpatient surgery center that's owned by the hospital and has a really tight connection. And then there's what Gary was talking about, a freestanding, fully private entity. And the risk tolerance for what you will do in those places may vary in each of those locations based on what your backups are, what your escape plan is. And so I found it very interesting. I went to a lecture at one of the ASRA meetings by an orthopedic surgeon from Florida, and their risk tolerance was astronomically high. I couldn't believe what they were willing to try. And then I asked him, I said, what happens when you have to admit somebody? He said, oh, we just roll them across the hallway. And I was like, okay, different story than what I'm talking about. Yeah. So that does affect, that context does affect your risk tolerance for outpatient surgery. And I was like, congratulations for what you guys have accomplished, but that's not going to apply to somebody who's in a freestanding facility that doesn't that transporting somebody by ambulance is a big deal. Melody, I want to come to you next. We've talked about sharing information. One of the things that you're really good at is education and disseminating information. How do people in private practice, and I'm really thinking about the people in the small places, where do you think is the best mechanism for them to continue learning? We live in an era of a lot of online tools. We live in an era of diminishing CME educational funds sometimes and things like that. What do you think about education for private practitioners now?
I think it takes a motivated learner. I'm really fortunate. The group I work with, when I first started, we were doing some bread and butter blocks, and then, we ramped it up. And I'm fortunate the colleagues that I work with are, very motivated to learn, particularly my cardiac anesthesiology colleagues. They're already facile with ultrasound, and they're just so ready and willing to learn, all the new blocks. They tell me that they're bored. And so I'm like, okay, let's go. But I think, it definitely takes a lot of self-motivation to, learn something new, to stay up to date, because like you said, we're not being spoon-fed it in private practice. You have to seek it out yourself. That's one of the reasons I'm so grateful for this SIG. I've been reaching out to Maggie Holtz, our chair, for years for her input on, how do we educate regional anesthesia, promote regional anesthesia education in private practice? How do we stay current and things like that when we're not, necessarily having grand rounds that is discussing all these things every week? It was, I think last summer I reached out to Jerry. I had a patient with a sternal fracture status post MVC. And it was a Friday. So our pain team right now has, I like to call banking hours. So it's really tough on
the trauma center
to get blocks in patients. It's just very variable depending on who's on staff and that sort of thing. But I had a patient, it was a Friday. She has MVC. She was having a really difficult time breathing and had the sternal fracture. And so I could do a single shot, but it's Friday, it's going to wear off. And I just reached out to Jerry because I figured if somebody's placed a catheter next to the sternum, it's probably Jerry Jones. And I asked, can you place parasternal catheters? Is that a thing? And he said, absolutely. And I did, and it worked. So I think like just relying on each other for these sorts of things when we're, you know, again, not getting information just handed to us, we have to seek it out. It's still very valuable. And it's one of the reasons I'm so grateful for this SIG.
I'm going to plug something real quick. So one of the projects coming out of our social media committee, which several of you have participated in, and a website committee, sorry, I should say, not the social media committee, is a tool called the ASRA Pain Medicine Best. This is a work in progress, but it's a building site. And the intent of this is to put video content from all over the web, different creators, and put their content, and it's curated so that there's a committee of people that looks through this to make sure that they assess its quality and value in the subject area. But the two things that I really appreciate on this is if somebody's made 1 or 2 videos, they can get highlighted here. We're not stealing anything from them. This takes it right to their website, to their content. They get credit for it. But they don't necessarily have to have the full website complement of every block to get noticed. And so we encourage people to go to this website. It's a great place to start. And the other thing that I like is that each thing doesn't have just one way to do something. Sometimes people they need a couple of different ways for it to be taught, for it to sink in, and you may not click with one way of education. So if you go in here, there's some things have a few blocks, some have several. I see Melody's got a contribution here too. She's got a few on here. And she's got a different style than somebody else does. And maybe you click with Melody's style, or maybe you click with the folks at Duke, or, and everybody's got a different perspective. So I just want to plug this because we're building this collection. And if you have made content, including point of care ultrasound, we're building the POCUS collection of stuff too. If you've made content, you can actually go to this website and submit a link to your content, and we'll review it and see if it's a good candidate for putting on the website. The big thing that we worry about is if there's a lot of bias, industry bias in the content, we want to make sure that's obvious or not present before putting it up on the website for people. But anyway, this is just, if you Google ASRA Best, you'll get to this website. So I just wanted to share that with people as a way of, again, when you're trying to seek education, how do you seek that?
Yeah, I remember when we started working on that, and it was so powerful because we've been talking for years. Raj and I have been talking for years about, all of our colleagues going to YouTube, and you're just like, oh, that YouTube is just, I don't know if it's got the right bias. I don't know if it's got, all of the information, but people love it for whatever reason. And so you have the Gupta score, if we all recall, as the
that was the original
rubric.
idea. We didn't stick to that one. I think.
No, we didn't.
We have a pain score now. We have a productivity, accuracy, the information, and then we do non-commercially industry bias.
Right.
And we try to have something for everyone. So we might have one of Melody's great videos if you have 30 seconds, or we might have like Jeff Gadsden and the Duke team, like if you have 10 minutes. So you get both sides of the story or information that you could view, and we're adding to chronic pain to that, more regional. It's a really great addition to the website.
Yeah, I was truly bummed that I timed out on the website committee before I really got to dig my heels into that one.
It's a momentum thing, it's all about building momentum. So, I mean, the key is that and where it comes back into the private practice SIG is, private practitioners like Melody are producing content and not necessarily the perspective of an academic institution that has, 14 people around to do one block, and there's some practical aspects of those choices when you're doing instructional material. And so somebody might not be able to reproduce the thing that's in the video from this high-end academic center, but they can reproduce something that Melody presents in a more practical sense in a small environment. And that's why I think it's really important to have a variety of different educational sources when you're learning something new, because it may not register one way and it can another way. So anyway, just to piggyback off of what Melody was saying about seeking information and making sure that you stay up to date. You have your colleagues, you have your network effect, and then you have online resources, and you want to make sure they're trustworthy.
Mm-hmm.
I can't believe it. We've been talking for 40 minutes, and I don't want to drag this on forever tonight, but I do want to give you guys an opportunity. So I'll just kind of go round robin here. If there's anything else, any tip or point you want to make to the audience about either where the SIG can contribute or some advice that you want to give to people who are maybe thinking about how do you build a program in your institution. And then I just do want to remind people, so much of this content is going to be at the spring meeting. So if you can get to the meeting, you're going to meet all of these people in person. You get to shake their hands. You can get to know them. Some of them might even give you their cell phone numbers so that you can call them in an emergency. But Jerry definitely will, because he likes phone calls all times of the day and night.
Actually, I did a NYSORA course with Gadsden. Guys, I think it was September, November. It was a couple of them we did. But there was a guy I met there, and he was learning. He was passionate. He's excited. He still sends me texts every couple of days or something. He'll say like, "Hey, do you think I can do an ESP for this thing?" Like, where's the like? And I'll draw him a quick picture or take a picture off. But I'm not going to take everyone's phone calls. But really, that's kind of what I think our SIG can be. This part of the website, Raj, this is fantastic. I've got tons of stuff now. I'm going to start looking at pushing that over. But I think we can be a network for each other. Again, for everybody, you don't have to learn every lesson. You learn your lessons and learn some of their lessons, and you put it all together. But what I would ask, or maybe say to everyone who is on the private practice SIG or interested or think it might have something, what I would ask is that you start bombarding us with, what do you need? Like these are specific things that people need. But what else do you need a better primer about how to bill your nerve blocks? You need better forms for documenting or for your regional anesthesia, or how do you prove to the hospital that these little Medicare nerve blocks you're doing are actually making a difference for this or for that? I would ask everyone out there to ask the private practice SIG, give us a project, give us something so that we can focus our efforts and interests. So that's my point.
Great, Jerry. Gary, why don't I come to you next?
So I know this is a regional heavy group over here with Jenny, Melody, and Jerry, and also Raj. I'm both. So for the chronic pain people, it's not just the American Society of Regional Anesthesia and Pain anymore. It's ASRA Pain Medicine. So for the chronic pain folks, people like myself doing your stims, peripheral, spinal cord stims, fluoro. I'll be teaching at the spring meeting for the acute pain folks if you want to learn lumbar and thoracic under fluoro. But for our chronic pain people, if you have questions with billing, procedure codes, new procedures, how do we bill this? This SIG is for you. And for our academic folks, you don't know where your career is going to take you, or you're going to go to private practice, switch back and forth. You want to know what you're building to show your worth to your hospital, your administrators, your chair, etc. So we're all encompassing and welcoming. We'd love to have you all.
Yeah, I didn't mean to ignore the chronic pain side of things, Gary. I felt like we would start going down a much longer conversation, and I want to give you proper time on that in the future. So
yeah, I'm outnumbered here too.
Back. No, it's not about that. It's actually completely about that.
Course.
It's completely.
I signed up for the Flora course.
I know I need to go do that. I just got reminded today. I was like, oh my gosh, that's right.
Yeah. Brian Seitz does all of his epidurals up at Dartmouth only under fluoro now. So every one of them gets put under fluoro. So he's been doing it for a while. I think he's going to be one of the instructors too for that course.
Cool.
So
he is. He's moderating the session.
Yeah. So it's not just talk. He actually walks that walk and makes it work in his hospital, timing and financially. So I think that's going to be a great lesson to learn over there. Melody, why don't you go next? So any last thoughts before we wind up?
Yeah, I would say for folks in private practice that are looking to build a program, find your early supporters, your early surgical colleague supporters. You may only have one. I only had one. And what will happen is they see the results. The results make the noise. The length of stay reduction, the opioid reduction, the increased patient satisfaction, the meeting milestones to discharge sooner. That is all very apparent to everyone. and it snowballs. I think for me, the toughest thing has been our growth has outpaced the resources available to us. So we just kind of like hit a wall, and we're like, okay, we want to do X, but in order to do that, we need more resources, and we're getting more. But that's where right now it's not the surgeons that are the roadblock, it's the resources. But when you're first starting out, find that early surgical colleague that's going to support you and give you a chance, and it will grow from there rapidly.
Yeah, I found that the other partner that was really helpful was my PACU nurses, because man, do they love you. They love you, and they get upset at the surgeons that don't ask for blocks, because they're like, why are your patients so miserable? And so they were my big advocate early on when I couldn't get the surgeons to buy in. That made a lot of headway. All right, Jenny.
Oh gosh, close it out, huh?
Close it
out.
No
pressure.
No pressure at all.
Well, I wanted to, I think one of the things that has always been prevalent within ASRA has been the camaraderie. And I think that is, super, super evident in this particular SIG as well. I know that Dr. Nuruz really pushed several of us to form this SIG a couple of years ago because he recognized that private practice was underrepresented in the faculty. And he really knows the value that we have, because we're such a huge percentage of practice within this country and internationally. So he, is at the helm saying, hey, we want to give you support. So I really, truly believe that ASRA has our back, and that, the challenge Jerry says of bring us your questions, bring us your projects, and use us as a resource, and see what kind of range. I mean, we have folks that are at level 1 trauma centers. We have crossovers between chronic and acute pain. We have Kaiser represented, everywhere in between, large and small group practices, where, the likelihood that we've seen something similar to what you are dealing with is probably high. And if not, bring on the challenge. I think that, we are a very collaborative group, and we just really want to support the people that come and want to work together with us to continue to build the prowess that is regional anesthesia, pain medicine, perioperatively, chronically, acutely, all that jazz. I just really love how much there is such a family, and I just want to spread that love to everybody.
Great. Excellent. And just as a reminder, like the private practice SIG is phenomenal and is quite sizable, but again, you have the entire society as a resource behind them too, and supporting them, and leveraging the knowledge base that's there, that maybe, if it hasn't been done in private practice, maybe it's been done somewhere else, and we just got to figure out how to translate it. So that's one of the beauties of having it within a larger organization. And I want to emphasize that ASRA, as Gary said, has changed its name to ASRA Pain Medicine. So it is that whole spectrum of the medical pain management field that's going to be presented at the meetings, in the content that we deliver on the website. It's the whole spectrum that we're looking at. Well, I could just talk with you guys, and I will when we get to Florida. I'm looking forward to that. I hope all of you guys will be there. Gary, say hi to your kid for us. I think he's ready for dinner. He's looking for his dad for dinner.
Yeah, he wanted to say hello quickly.
That's fine. He come wave. But thank you guys. For those of you interested, I put the link in the comments, or it was also on the on the video, but just go to ASRA.com, look for the Private Practice Special Interest Group, get involved, and I think you'll find this amazing. Thank you guys for coming. It's been so much fun talking with you. I can't wait to see you in person. I'll see you guys in Florida. Thank you, and have a good night.